Hi, everyone. So I just wanted to, you're going to have two introductions to this video. A couple of things. Merged together a video I just recently recorded with a video I recorded in my last year when I taught this class. And so the second part of this video is going to have some references to lecture and in session. At that time, we were doing like a hybrid class. So I don't want to throw you off. You didn't miss a class or anything like that. Okay. So this video is about an hour long. So if there's a gap of silence, don't think it's over. Just kind of fast forward or be patient and the next part will come up. Okay. I just want to make sure you have this information and I'm a little bit behind. Hi, everyone. I hope everyone is doing okay in the course. Okay, I know it's a lot of information, and I'm hoping that these videos and my PowerPoints are making it a bit easier to understand and reinforce your learning. Okay, right. So, just a couple of housekeeping things first. I posted a previously recorded lecture reviewing action potential and highlighting a few slides from Module Three's PowerPoint. I encourage you to take a look at it. You might find it helpful. Okay. Also, as a reminder, if you are scoring less than an 80 on your quizzes and you did the reading, please reach out and we can schedule a Zoom meeting just to see how I can support you and see maybe you're looking at the material a certain way or kind of look at your thought process and why you selected the incorrect answers. Okay. All right. So, hopefully, this slide looks familiar. It is a visual representation of the four dopaminergic pathways hypothesized to be involved in psychosis, right? As a reminder, hyperactivity in the mesolimbic pathway is associated with positive symptoms. Antipsychotics, D2 antagonists will block dopamine receptors, preventing endogenous to D2 receptors. This is believed to decrease the dopaminergic activity in the mesolimbic pathway and reduce positive symptoms. Okay. Now, I'm not sure if I mentioned this in the previous lecture, but the mesolimbic pathway is also involved in motivation, reward, and pleasure. Right. So when you block D2 or D2 antagonism can also decrease motivation and pleasure and produce so-called secondary negative symptoms such as anhedonia and apathy. Okay. And a decrease in motivation. And so this is one of the reasons why you may see an increase or a high incidence of smoking and drug use in people with schizophrenia or other psychotic disorders who are being treated with antipsychotics. Now, this is not the only reason. Recently, I was watching something on Nick Reiner. Remember Nick Reiner? He killed his parents, filmmaker Rob Reiner. And in this interview, he was saying that initially he used meth and different drugs because he wanted to quiet the noise. Now, he was subsequently diagnosed with either schizoaffective disorder, some type of schizo disorder, but this is just what's coming out. You will see a high incidence of substance use even when patients are not being treated because sometimes the substances can quiet the noise. And what might the noise be? It could be fixed delusional beliefs. It could be okay. It could be seeing things. All right, but I want you to keep that in mind. Okay. All right. And then regarding like once you give them patients antipsychotics, smoking and drug use, it's a pleasure seeking behavior. Okay. And it's to mitigate the negative effects of the D2 antagonism within the mesolimbic pathway, within the pleasure and reward pathway. All right. Okay. So primary negative symptoms, right, and cognitive symptoms are associated with hypoactivity in the mesocortical pathway, right? So we're talking about negative symptoms like reduced speech, poor grooming, limited eye contact, like flatness, a lack of interest, and reduced social drives. Okay. Now, medication that blocks D2 receptors in the mesocortical pathway will further reduce dopaminergic activity and negative symptoms can worsen. right? So then why do we use D2 antagonists, you might be asking? Well, it goes back to that benefit and risk analysis. As a reminder, D2 antagonists are effective in decreasing symptoms of psychosis, but they operate on specific receptors. Okay, they operate these not on specific dopamine receptors in specific pathways. Okay, so it boils down to almost a risk benefit analysis, and that decreasing some symptoms you may worsen others. And this is really important to understand when you're prescribing any medication, like antipsychotics, antidepressants, any medication. So when you decide to prescribe medication for your patient, consider the side effects, consider their quality of life, and consider their presenting level of debilitation. There is I'm going to share this video, but there's a man, I believe his name is David Carmichael, and he was put on Paxil, SSRI. He was put on Paxil because he was feeling down because of his finances and different existential type kind of conflicts, if you will. You know, what's he doing with his life? He doesn't have any money, that kind of stuff. And he was feeling down, but he was still working. Okay, so you want to assess the level of debilitation. So his prescriber put him on Paxil. Now, he upped his dose of Paxil because he wanted to feel better, or there's some history, and I'll share the video. He had a psychotic episode in part because he blames it on the medication, which it absolutely could be, and he wound up strangling his 11-year-old son. Now, he had no history of psychosis. He had no history of abuse. As a matter of fact, he was found to be not guilty by reason of insanity. He was hospitalized for a couple of years, and then he returned to live with his wife and other child because they understand that this was so out of character for this man to commit such a heinous crime. And so I say that as not to say that you shouldn't prescribe medications, but you also need to think about psychotherapy, and you also need to think about the level of debilitation. Is the person working? Are they just down? Is there a level of discontent that they're just not satisfied with their life, and they need to figure out how can they accept where their life is today, and what can they do to change their life? And does that happen through a pill, or is that something that they need to work on in therapy? Okay, because there are risks involved. Now, again, I don't want you to feel like you shouldn't prescribe medications when warranted, but you just want to start low, go slow. That is the rule. You start low and you go slow, and you always want to bring in therapy. Okay, and patient education. You know, a lot of times we don't tell patients that, there is a risk of psychosis. It's very rare. There is a risk of suicidal ideation. It's very rare, but we should tell our patients. Okay. All right. So let's see. Anything EPS is way. All right. And tuberoinfundibular pathway, that's associated with hyperlactinemia, which is the men growing breasts, the women stopping their period, and also breast discharge, okay? Milk discharge, I'm sorry, from the breast. All right, so let's take a minute and look at this case quickly. So Mike is a 24-year-old graduate student with a history of mild asthma. He is brought to the CPEP, the psychiatric emergency room, by his sister due to 3 weeks of progressive paranoia, auditory hallucinations, and disorganized speech. He believes his classmates are monitoring him through his laptop, and he has been socially withdrawn. So we're going to add pi this case study, okay? So what's the first thing you're going to do? You're going to conduct your assessment. All right. So in conducting your assessment, you want to conduct a mental status exam. Now, this is a psychopharm class, so we're not really going to get into assessment that much, but I want you to look at this cheat sheet, if you will. All right. And in a mental status exam, we're documenting the patient's appearance. Are they well groomed? Are they casually dressed? Do they look disheveled? Okay. What's their behavior? Are they calm? Are they irritable? Are they acting psychotic? Are they disorganized? Okay. How their speech and language, their mood, their affect, and you can read through it. Okay. Now, for the case study, you're told that Mike is experiencing auditory hallucinations, paranoia, which is fixed beliefs that somebody is trying to get you, hurt you in some way, disorganized speech, okay, and negative symptoms, he's being socially withdrawn. All right. So that's what he's experiencing. So we're applying it, right? So now you're going to start this, okay? What could it be? Okay. Is this substance did he take a mushroom? Did he take some LSD? Did he take some type of drug, smoke weed laced with something? All right. Is it substance induced psychosis? How will you know? You're going to do a toxicology. Okay. You're going to ask about his history, ask his collateral about any history of substance use. Okay. Does he have a diagnosis of schizophrenia? Has he had psychotic episodes in the past? Is this his first psychotic episode? Is this the first time he's ever acted like this? Okay. Does he have a history of schizoaffective disorder? What is schizoaffective disorder? This is where you have the psychosis and you also have the mood symptoms. Okay. So you'll have mood disorder and depression, and you'll have schizoaffective psychosis. Okay. Is it a bipolar disorder? So a bipolar disorder is you'll only get psychotic when your mood is elevated or your mood is really low. So it's only during the phases of bipolar where you have psychotic features. Okay. Because sometimes you will have bipolar with psychotic features. Not everybody who has bipolar gets psychotic, but some people do. How does bipolar and schizoaffective disorder differ? Well, this is very tricky. You guys can look it up, but basically, a schizoaffective disorder, you can be psychotic even if the mood is normal, neutral, stable, when you're not depressed, when you're not in a manic episode. All right. So, but bipolar, you're only going to have psychosis if they have bipolar with psychotic features. Then you're only going to see psychosis with an up or down with that mood lability. See it. Whereas in schizoaffective, you can see it. Okay. Is this major depression with psychotic features? So you want to formulate a working diagnosis based on the presentation, based on the history. And again, remember, your working diagnosis is something that will evolve over time. Okay. But it's important because if it's substance induced psychosis and based on the toxicology, you might give them something and then let them come down off of it. Okay. All right. So planning. Oh, one thing I also want to say, creating safe treatment, right? Directing further assessments. It's a way to communicate Mike's presentation with another provider, with insurance companies, Mike himself and his family. And you want to keep in mind that the psych ER, the hospital, they're going to need to get paid for Mike's care. So they have to submit claims to Mike's insurance company. And if Mike is not insured, then maybe they submit claims to Medicaid for care rendered. Whenever you submit a claim, you have to have some type of code. Okay, you have to have an ICD code. 1 second. All right. Don't want to take it for granted that the diagnosis is set in stone. All right. So when you have a patient and the patient has a history and you see that there's previous diagnosis, continue to assess and evaluate and reassess and reevaluate your patient each time you meet with them. This is very important because patients' presentation change over time. I was reading something not too long ago. I don't think I could find the actual statistics. Can I find the actual statistics? Let me see if I can. Hold on 1 second. No. Let me see. Yes. Okay. So patients that are diagnosed with major depressive episode with psychosis, um, a long-term study showed that a lot of these patients are subsequently diagnosed with schizoaffective disorder. They're subsequently diagnosed with schizophrenia disorder, and they're also subsequently diagnosed with like a trauma disorder. So it's important to understand that you're making a diagnosis in a moment of time, but the patient's presentation will evolve. You have to get to know your patient, and so you don't remember, diagnoses are not stuck, they're not written in stone, and you want to always assess and continue to assess. And if you get a new patient with a certain history of diagnosis, don't take it for granted. Make sure and don't have like a bias. You make your assessment based on your presentation, based on the questions you need to answer. Okay, it doesn't mean that you ignore the history, but it also doesn't mean that you use the history as the only source of uh, in clinical decision making. Okay, all right. So, um, all right. So, yeah. Next step is planning. Okay, so remember, the goal of psychopharm is not just to match the drug to a DSM diagnosis, to match a drug to the underlying brain or brain circuit dysregulation when possible. Okay, to have a strategy, to have an understanding of what you're giving, why you're giving this. Okay, so based on Mike's presentation, we understand that there's probably hypoactivity in the mesolimbic pathway, and this is causing significant psychosis. Okay, his auditory hallucinations, the paranoia, the disorganized speech, right? So we need to give some type of D2 antagonism in the mesolimbic pathway. All right. We also have some dysregulation in the mesocortical pathway pointing to social withdrawal. So our implementation will include prescribing a first or second generation antipsychotic. Now, also, I hope you guys had a chance to look at the APA guideline that I posted in Moodle in terms of what are you supposed to do? What else do you want to do in terms of the implementation and planning and implementation phase, right? We'll get to that in a second, but all right. So you're going to prescribe a first or a second generation antipsychotic. Now, in general, we you know usually the first line for patients with psychosis or schizophrenic type disorder, schizophrenia or other psychotic disorders is usually going to be a second generation antipsychotic, right? But in certain, and this is because the positive symptoms are targeted, the negative symptoms are targeted. But sometimes, there's an art involved, okay? So, first generations, including Thorazine and Haldol, are strong D2 antagonists. This is correlated with the therapeutic and side effects we previously discussed, such as EPS in the nigrostriatal pathway and hyperprolactinemia in the tuber infundibular pathway. All right, but on the other hand, second generations have more moderate D2 antagonism compared to first generation antipsychotics, but they also have strong serotonin 2A antagonists. And so, you know, there is there's that difference, okay? Antipsychotics also block histamine, muscarinic, and alpha receptors. I posted a video on the sympathetic versus automatic nervous system. I suggest you review, especially the second half of it again. When antipsychotics block histamine receptors, it causes sedation and some weight gain. When antipsychotics block muscarinic receptors, acetylcholine receptors, this causes like dry mouth, dry eyes, and constipation. And then when there's blockage of alpha adrenergic, alpha 1, receptors, this can lead to orthostatic hypotension and some dizziness. Okay, so that's kind of your planning. All right, what you're thinking about, what you're gonna do, you're thinking about the side effects. So in the ER, Mike is diagnosed with schizophrenia and he started on Haldol. Now you're probably asking yourself, well, ask yourself, do you agree or disagree with the psych NP's decision to prescribe Haldol? You may or may not. You might be thinking, well, Haldol is first generation. We know that starting treatment is second generation. Why would they give the patient? Well, you got to understand that prescribing is an art, right? We try to follow, you want to follow best practices, recent evidence, but unless there's a direct contraindication to what you're prescribing, there is some, well, there's some degree of clinical judgment involved, right? Where you tailor your choice of medication, your dose, and the time based on the person that's sitting in front of you. Okay, so some of you might question the decision to prescribe Haldol, first generation antipsychotic, because it could potentially worsen Mike's negative symptoms of social withdrawal. But keep in mind, in an emergency situation, sometimes IM Haldol is often given for acute agitation and psychosis because it's really fast acting and effective. And if Mike tolerated that Haldol IM really well, maybe the nurse practitioner is like, okay, he did really good on his Haldol. I'm just going to discharge him on the PO Haldol. Okay. Because if you give him something else, you're not necessarily sure that it's going to work. But right now, he's stable. Would I have done it? No. But, everybody is prescribing differently. And unless, like I said, there's a direct contraindication, it's acceptable. All right. So what are we doing here? All right, so you want next step, you did your implementation. Also, your patient teaching. I don't know if I said it. I might have, I'm sorry. But refer to the APA guidelines on schizophrenia. Patient teaching is very important in terms of medication adherence, in terms of side effects, in terms of this is a life-changing kind of diagnosis, right? There's a high rate of suicide in this population, especially when you're first diagnosed, okay? So you want to look at that. So read over the patient teaching because it's very important within the implementation plan. Okay, so you prescribe and then you're going to reassess. Okay, so Mike comes back in for his follow up after, let's say, 2 weeks after discharge, and he's starting to experience. He's getting very, very negative, but he also is walking really slow. His gait is really stiff. He's having like tremors. He's almost like doing a shuffle kind of movement, Parkinson, like a Parkinson kind of patient. And so you know that he's experienced EPS symptoms. Okay. And so what are you going to do? Are you going to give him medication to mitigate the EPS symptoms? Are you going to give him cogentin or other cholinergic medication? No. He's 24 years old. Okay. He was on Haldol. We know Haldol's first generation antipsychotic. You're going to titrate him and you're going to put him on something else. Okay. You can try to put him on something like Abilify. Okay. All right, guys, I'm going to try to go through this really quickly. I hope you can hear me. The problem is with this computer, the sound is usually low, so I am going to try to speak as loud as I can. And oh goodness, I hope that you hear me because I don't want to go through this again. So, do this. So for this slide, just read through. You want to make sure you understand that the mesolimbic pathway is a in this path, dopaminergic activity in this pathway is responsible for positive symptoms. When we give the drugs, the D2 antagonist or the serotonin dopamine antagonist, which is your second generation drugs, it also does reduce positive symptoms. When you give just the D2 antagonists, there's the potential of causing drug induced or drugs can cause secondary negative symptoms due to decreased activity. And this is your adonia, and your apathy. Okay. And I'm not going to go over all of these, but one thing that's important to note is that any kind of movement disorder is usually associated with the nigrostriatal. And so that can be acute dystonia, that can be EPS. Okay. Um, the tuber and fundibula. Just again, I said this in class, but this relates to both men and women. So you want to make sure your patient education and your patient teaching includes both men and women. And if you don't know, look it up. You should know what it does to women and what it does to men. Okay. All right. Okay. And Parkinson, Parkin, Parkinsonism. Okay. You don't have to watch the whole thing, but you should just watch like the first, I would say 30 to 40 seconds because it just shows you the shaking and the tremors. Okay. Um, understand the difference between EPS and tardive dyskinesia. Understand the onset, the different onsets. This is very important. If you look at my notes, I think my notes talks about it, but the acute dystonia, this can happen within a few hours, immediate to within a few hours. Why IMs are given with Ativan and Benadryl because you don't want to give a patient an IM and cause acute dystonia. And remember that anticholinergics make DT worse, so we don't want to give it to patients who have TD. That's another reason why you need to understand the difference between your EPS type symptoms and your TD. I'll look for a video, but remember, it's like the lip smacking, stuff like that. Okay. All right. You also want to be mindful of the anticholinergic burden, including non-psych You also want to assess non-psych meds, right? Like, so is the patient taking another anticholinergic, right? Because too much of the anticholinergics can lead to um, cognitive dysfunction, really memory issues, concentration issues, right? But also paralytic ileus, okay, which is a severe life-threatening um, reaction, okay? Right. And then also remember that the risk of TD increases each year on antipsychotics. And if it goes on too long, it can be irreversible. Now we have the new medication and Austedo. These medications are VMAT2 inhibitors. And so they can really make a difference. But you want to be able to differentiate between EPS symptoms and TD symptoms because you don't want to think it's EPS and give your patient anticholinergic and make the TD worse. Okay. For neuroleptic malignant syndrome, all right, I'm not going to go over what this is. It's just important to remember these are your treatments, and you don't want to use like antipyretics because it's not really helpful because patients' fevers can shoot up to like 105. This is why we need a cooling blanket. All right, and in order to have this diagnosis or for a patient to have this um, life-threatening side effect, they have to be on a neuroleptic. Okay? And you look at the labs. Okay? All right, so here's your routes of administration. So we have your PO, you have your oral. Um, Adherence is an issue. If it is an issue, convince a patient to take a long-acting injectable. But remember, before administering, you need to give them a PO trial for a significant amount of time. Um, Intravenous is not often used. Like I said, rare cases. Sometimes in hospice care, end of life care, but I've never seen it used for antipsychotic. And so we have two IMs. We have IM depot and IM, just regular IM. A regular IM is what is a shot that you just give a patient on the unit, or like I said, in a nursing home when the patient is aggressive or violent, it just knocks them out, calms them down. Okay, and these are the cocktails that have the Haldol, Benadryl, and Ativan. Okay, and they might have other drugs too, but that's just an example of a cocktail. All right, your intramuscular depots are your long-acting injectables, and these are the medications that can last up to 2 weeks. Haldol has the 2 weeks one. You have I think that someone mentioned that Zyprexa has a 6 month one. But in order just to remember this, I want you to remember the mnemonic Oprah F. That should help you remember which ones are long acting. Okay. All right. So Thorazine, remember this is the first D2 antagonist. It was developed as an antihistamine. If you look here, it binds with D2, but it binds stronger with histamine 1 and alpha 1. And this is which explains why it's so sedating. It is the most sedating antipsychotic. And it also has such strong orthostatic hypotension and EPS. And so the orthostatic hypotension or other cardiac side effects, cardiovascular side effects, are usually associated with the alpha 1 antagonism. Okay, thorazine is still used today, but only in highly agitated patients or patients that's been on this medication since the 80s or something, right? So these are older patients, okay? You do want to monitor for QTC prolongation, and there is potential photosensitivity with this medication. All right, so Haldol. So, I mean, with any medications, any antipsychotics, you always want to assess the symptoms, right? What are their current medications? Are they on inhibit the enzymes that that break down Haldol? If they inhibit the enzymes that break down Haldol, then the drug is going to build in your system. Why? Because it inhibits the actual enzymes that break down the drug. So if those drugs are inhibited and they're not doing their job and breaking down the drug, what happens? the drug builds up in your system. And why is that a bad thing? Because too much of the drug is going to cause increased side effects and toxicity. You also, when you're assessing them, you want to talk about what are the previous antipsychotic trials. Again, this is for all most of these antipsychotics. What are the previous trials? Haldol, because they have most people. Haldol is used is really good for positive symptoms, but it's not our first line of treatment anymore. First line treatments are going to be like your second generation. But if the patient had multiple trials on second generations and they had like really bad metabolic symptoms and they have really bad diabetes and they're like super overweight and they just have positive symptoms, you might have no choice but to put them on Haldol. Okay. All right, and then you want to know the history of compliance. You want to make sure you do your baseline screenings. Okay, what are their basic labs? Do they have any movement disorders right at the present? Is there any tremors? Is there any signs of TD? Okay, you want to look at that, and if there is, you want to think about, well, what are your options? Is there anything else? Oh, I can't put them on anything else because they've been on everything else, and this is the last thing I can put them on. Okay, so then you want to start using that AIM score, and you also want to give them the VMAT2 inhibitors. Okay, we make this diagnosis. Haldol is used, like I said, not just in schizophrenia, but in all the other most of the disorders in the DSM-5 under schizophrenia and other psychotic disorders. So schizophreniform, schizoaffective disorder. Okay, and you should read the DSM-5 and see what these disorders are. All right. So why would you be considering Haldol? We talked about that. You want to think about the side effects. Haldol's less sedating and less anticholinergic effects, but again, because of the alpha one um, antagonist, it can cause hypertension, EPS, and TD is very common. Okay, because it's in bold letters here. Okay, so implementation. How are you going to prescribe this to your patient? So you're going to give them PO to start with, right? Well, let's say the patient is currently on you started the patient on PO medication, Haldol, and they're doing really, really well. It's been a couple of months, no serious side effects. But compliance is an issue. They keep on forgetting, they have memory issues, what have you. Okay, so what are you going to do? You're going to look at a long-acting injectable. Okay, Haldol, Decantate, I forget what they call it, but they're going to look at the long acting Haldol Decanate. Okay, the Long Island, oh gosh, the long acting injectable. All right, and I'm not going to tell you the dose. Go look in the prescriber guide, and remember, you want to always start your patient in terms of PO medication on the lowest dose. Okay, and then build up because you don't know if somebody's like a super fast metabolizer or a slow metabolizer of this medication. All right, other considerations: age, previous side effects, substance abuse, and smoking. Why substance abuse and smoking? Um, why substance abuse and smoking? Because um, sometimes some of the substances can inhibit or induce the medication, and the Haldol can build up or go to a low level, a subtherapeutic level, have like a relapse of psychotic symptoms, especially patients who are psychotic and especially patients who are psychotic. Sorry, Maggie, go in a cage. Who are psychotic and have like command auditory hallucinations, telling them to hurt themselves or hurt other people, or they have like delusions that the people are demons and trying to kill them. These are the people that push people on the train tracks because they're so delusional or they see things. Okay, all right. And then patient and family teaching, which I think you guys know. And then you want to evaluate the effectiveness and side effects, okay? And IM is given as a cocktail. We give the Benadryl and the Ativan. We already explained why we give that. Okay. And this video here, I encourage you to watch because it talks about ocular gyrus crisis. And so um, it usually happens in older people, but not always. This kid is young. But basically, your eyeballs get stuck to the back of your head, and it's like you can't see anything but up. And so sometimes patients will fall just trying to see. Okay, so yeah. So you can look at that. All right. So just to kind of like touch on this real quick, the inhibitors, okay, these are medications that are inhibitors in the CY, did I spell it right? CY P450 family. Okay, I think, we tell patients all the time, you'll be surprised how many prescribers put their patients on medications and don't tell them that don't take grapefruit, don't eat grapefruit or take grapefruit juice with this medication, because if you're taking a medication like Prozac, or even if you're taking an antipsychotic and you take grapefruit with it or grapefruit juice, it can inhibit those enzymes that break down the Haldol, and that causes the Haldol to build up in your system, which can lead to toxic levels and side effects. Okay, so let's say for that patient that we were just talking about here, that we started on the Haldol and they were doing really well. Okay, but they decided that the smoking is causing their throat to, they want to stop smoking. No, yeah, they want to stop smoking. So or maybe you don't, bu- bupropion, which is also Wellbutrin, is also an effective smoking cessation agent. So you can give people 150, 300 milligrams of Prozac of bupropion, and it will make the cigarettes. And I know because I smoker will make the cigarettes taste like dirt. And so it really helps people kick the habit. The problem is if they're already taking an antipsychotic, that bupropion is going to increase the level of that antipsychotic. So if you're going to start somebody on bupropion, you really have to start them on a low dose. You have to adjust the antipsychotic, the level of the antipsychotic, and you want to start them on a low dose of the bupropion. But even if you do, you need to adjust the antipsychotic, and you have to watch them for signs of BPS, EPS. You have to watch them for adverse reactions. Okay. Now, inducers are, when inducers are something that like speeds things up, it causes something to happen, right? So certain medication and substances are inducers for the CYP 450 family. And that means it causes that, say. And so it can break the drug down more, and you'll get to a level that's not therapeutic. You'll get to a subtherapeutic level. All right. So going back to that same patient that's on, let's say, Haldol, and okay, the patient doesn't actually want to stop smoking, but you know what happens? The patient's, let's say, public assistance benefits were cut off, and now they're not getting their monthly cash. And so they were a heavy smoker, they smoked 2 packs of cigarettes a day, but now they don't have their, cash benefit, and so they can't afford it, or they lose their job, whatever it is. They can't afford to buy their cigarettes anymore. So now they go from smoking 2 packs a day to smoking one or two that's bummed off of other people. So what's going to happen now? So now they're not taking that inducer into their body on a consistent basis. Now every day they're not taking the tobacco in. So your prescriber adjusted the medication based on the patient's current state. So because the patient was smoking, the prescriber understood that the Haldol is broken down more. Okay, and let's say its dose is 2 milligrams a day. Let's say 2 milligrams a day. Okay. Now the prescriber has is aware that the patient smokes tobacco every day, smokes cigarettes every day, and the patient is doing well on that dose. But now, once the tobacco is removed, because now the patient can't afford the cigarettes, so the patient is going one day without, a couple of days without cigarettes, what could potentially happen to that patient in terms of their Adderall? Because now they don't not taking in the inducer that's breaking down the Adderall, I'm sorry, the Haldol. So the Haldol could actually build to a level that is going to be cause problems for the patient. So because the patient is no longer smoking 2 milligrams, it's actually going to be higher than it had been the months before, because all those other months the patient was smoking the cigarettes, and the tobacco was causing the enzyme activity, the CYP enzyme activity, to be activated and to be high, if you will, which left like a lower amount of Haldol available in their system. But because you remove the cigarettes from that patient's profile, now the Haldol the CYP is going to break down the Haldol like it normally would. And so the patient is going to experience a higher dose than they have been experiencing the previous months when they were smoking. That's why it's really important that if you're prescribing for someone who's a smoker, you have to tell them, listen, if you decide to quit or if you start to decrease, you have to let me know because we're making this, I'm prescribing you this dose based on the fact that you smoke because the smoking will decrease the level of Haldol and we need to keep a therapeutic level. And you educate them, but you also have to assess them because sometimes they'll forget to tell you because maybe they just forgot to tell you they what's going on. That's why you also have to ask your patients, well, what's going on in your life? How's everything? How's things going? Fine. Any changes? What's your situation? And you have to know your patients. And they say, well, I got really upset because I went down to social services and I got really mad. Oh, well, what happened in social services? Well, why did you have to go down there? Oh, well, because they cut off my food stamps or they cut off my financial stipend and now I don't have any money. Well, are you still, are you eating okay? Are you still smoking cigarettes? How are you buying your cigarettes? And it seems like a silly question to ask, but so it's kind of tricky, but as long as you're like paying attention to your patients, and I hope you can hear me, because if not, I don't know what we're gonna do, because I can't record this again. Atypicals, okay. All right, I'm not going to go over this particular slide. You can read it for yourselves, and I think I made some notes below. You have your pines, your dones, your pips, and your rips. Okay, your pines are strong. Oh gosh, where's my glasses? Your pines are strong serotonin antagonists. Okay, but they cause severe metabolic side effects, heavy sedation, and well, actually, EPS is unlikely, and so is actually heavy sedation, but they cause severe metabolic side effects. That's the key with the pines, right? And so think about your olanzapine, maybe it's the peens. Think about your olanzapines, your clozapine, and your quetiapine, which is your Seroquel. Okay, your dones, your risperidone, your lorazepam, your ziprasidone, okay, which is your geodon, and your palperidone. Your dones block the D2 antagonist less than the first generation, but more than the pines. So there's a higher risk of EPS and hypoprolactinemia, but there's less sedation and weight gain. And then you have your PIPs, which is allows some receptor because it's partial D2 antagonist. Okay. All right. So Clozaril. All right. So Clozaril was the first second generation antipsychotic. The first second generation antipsychotic. And I told you this before. Clozaril really is the most effective treatment for schizophrenia, but the side effects can be lethal. And so, some studies also show that it helps with negative symptoms. Um, and the thing is, there's this paradox here, and I don't know if I described it in class, but if you notice, where the D2 blocker is, I'm sorry, the D2 receptor antagonist, it's here, but all these other receptors are stronger and they're stronger antagonists. Okay. All these other receptors compared to the D2 binding. And so this is a paradox because if D2 is the big thing, the big receptor, the primary receptor involved in schizophrenia and related symptoms, then why is such a weak D2 blocker the most effective drug? But um, serotonin the serotonin, the partial um, 5H2 antagonist, it can it can help modulate the mood. Okay? And so, why is Clozaril only used in treatment-resistant schizophrenia? Again, because of the agranulocytosis and also because of seizures. Right? And there's a protocol, and it's called the Clozapine Risk Evaluation and Management Strategy, REMS. Okay, and so here's the protocol. So for the first 6 months, you do an absolute neutrophil count, or ANC. Once the ANC drops below 500, you have to stop the drug. There's no getting around it. Okay. So for the first 6 months, you do this weekly. And then the second 6 months is every 2 weeks weekly. And then after the first, oh no, this is wrong. After the first 12 months, it should be monthly. This should be monthly. Okay. But it never changed from it's always monthly. All right. And the thing is with this is compliance, because who wants to get their lab done every week? Unless you're in a facility, it's easier. But like if you're out in the community, it's very, very difficult. Um, but if you have, I believe it's either 2 or 3 failed tries, and you have a patient that you know will be compliant and is really struggling, you can look at clozapine. Right? But you have to register them with the REMS system, and you should take a copy and paste this link and just look at it and familiarize yourself with it. All right. So clozapine, we talked about this. You want to assess risk factors, history of family, history of personal. I made a mistake on the slide. History of personal or family history of cardiovascular disease, any other comorbidity, seizure disorders, common side effects are here. Monitor for the ANC, myocarditis, rare hypolactinemia, but it can happen. Weight, BMI, and other metabolic issues. Okay. All right, we talked about this. It's lithium and clozapine. All right, so Seroquel, I put that as a 3-in-1. So what does that mean? It means that it can be used as something for insomnia, as a sedative at a low dose. Like a lot of times you'll see prescribers giving 50 milligrams of Seroquel at night for people who have like anxiety or depression or who just can't sleep. um, and put a pin in that because I want to talk about that. Then at a higher dose, like 200, you'll see like it works as an antidepressant. And then at the higher doses, like 600, 800, it works as an antipsychotic. But I mentioned this that as the dose gets higher, the side effects become more pronounced, okay? Including weight gain, orthostatic hypotension, and even where this cataract formation can occur. And so if you look at the you can see that it's an alpha 1 antagonist. Okay, so this is why you have your orthostatic hypotension. Um, Muscarinic is here. Um, Histamine is the biggest one. And what does histamine cause? Weight and sedation. Okay, so this is why these stall, I know it looks like switch scratch, but it's not. And it's very helpful to visually help you understand why patients are having side effects. Okay. All right, so Risperdal is very good. Okay, it comes in PO or IM. Risperdal can start Consta is every 2 weeks. It's very effective for psychosis. You want to assess for risk factors and pre-existing conditions, and think about what pre-existing conditions you want to assess for. Okay, it causes in high doses. It can cause higher incidence of EPS. Okay, less weight gain compared to clozapine and olanzapine, but still some weight gain. But the biggest thing among Risperdal is the hypoprolactinemia. That is the biggest thing. It's the biggest thing among anti second generations. Is the worst one. Okay, and remember I told you about my patient who was doing the skin picking, and I gave it to her, and she did so much better. But then we had to stop because of the breast secretions and the amenorrhea. Okay. All right, so you definitely want to monitor your weight, BMI, waist circumference, serum levels, and glucose. And in general, you should monitor that for all your patients. Okay. Palperidone is an active metabolite of Risperdal, and they have extended um, Invega Sustainer, which is pal. You want to just give them a trial of palperidone as well. Okay. Some people don't, but I would. You want to be prudent and you want to be safe. Oh, and another thing is that I forgot to put the pin in. We're here. Oh, a lot. I think that prescribers really do give this too casually in sleep. You can't sleep. Just take 50 milligrams of Seroquel because there are side effects, and there's this potential risk of side effects, right? such as weight gain and such as cataract formation and orthostatic hypotension. And, it can interfere. It is an antipsychotic and it can cause metabolic syndrome. It doesn't happen that much with Seroquel. I mean, it does happen, but you know, the thing is, at the low dose, there's an argument to be made that it doesn't happen as much. But if somebody's taking this medication chronically for like 10 years to sleep, it just shouldn't be your first choice, and you shouldn't approach prescribing these antipsychotics very, very casually. You really shouldn't. Okay. All right. So, Keodone, I really just want you to read the slide. Important takeaways. You want to take this with food. Um, but also think about QTC prolongation. This is the bump in your heart, okay? It's rare, but it has the highest risk, okay? You want to avoid other drugs that cause QTC prolongation. So, this is why you have to know your drugs. And if it's hard for you to remember when you go to practice, just have like a cheat sheet, okay? Because maybe you'll remember for the boards, but maybe you don't remember in practice, but have a cheat sheet. I have plenty of cheat sheets that I look at, okay? And it also can cause drug reaction with eosinophil and systematic symptoms, stress, okay? You can look that up. Common side effects are sedation and dizziness, but the biggest is the QTC prolongation. So you really want to assess family and personal history for all your patients, including cardiovascular, I said eating disorders, and anything else you can think that a patient might be risk of electrolyte imbalance. Okay. Like patients who just had MIs or patients with chronic heart failure. Why? Because you need your electrolytes, especially potassium and magnesium, to be balanced in order for the heart to beat and perform properly. Zyprexa is effective with psychotic symptoms, but metabolic syndrome is a problem here. Weight gain, hyperlipidemia, increased glucose, increased liver function tests. Right. Again, it comes in different formations. PO, immediate IM, like for the patient that's becoming agitated or violent on the unit, and long acting. It does cause mild prolactin elevation. So you want to monitor weight, BMI, waist circumference, monitor your lipids and your glucose. And they have a long acting is called Zyprexa Relpreve, I think it is. It's given every 2 to 4 weeks, and it requires that clients be monitored for 3 hours after injection. Observe them for delirium. Okay. Latuda, Latuda has the most akathisia, more EPS than other atypicals. Um, it's mild sedation. See, not really. It's not even here. Okay. Some nausea, QTC monitoring. You want to take with food. Okay. Abilify, the partial agonist. I'm not going to read through this. You can read through it. Okay. Again, look at this. Other drugs that you can study. Okay. And I think that's about it. Yeah, for next 6 and 7, I really want you to focus on the drugs. Don't get lost too much in the neuroscience parts, particularly like 5-HT7. It's just don't get lost. Hi guys, I'm just adding this quick snippet into your video because I don't feel like I fully explained it in my other videos, okay? And I wanted to go over it with you. So, I'm sorry. What is the primary treatment in schizophrenia? All right, so the primary treatment in schizophrenia is going to be antipsychotics, second generation antipsychotics, but it's not the only treatment, right? You may also see antidepressants, anti anxiety medication, and anticonvulsants. And we'll get into anticonvulsants when we talk about mood stabilizers. All right, so that's one thing. Also, when we're talking about psychosis, if someone is coming in with substance induced psychosis or psychosis due to infection, like delirium, or psychosis due to medication interaction or overdose of medication. All right, in these cases, you might not necessarily give someone an antipsychotic. You might remove the agent that's causing harm. Okay, so if let's say somebody is having psychosis because they're detoxing, right? Like they're detoxing off drugs. Well, then you're going to send this person for a medical detox where they'll get fluids and some type of benzo, equilibrium. It depends on what the drug is, what the substance is that they're withdrawing from. Sometimes if it's psychosis induced a substance, like if they took LSD or if they took marijuana laced with something, sometimes it might just be that you might just allow the medication to excrete through the body, and you might give fluids, and you might give perhaps a benzodiazepine. It just depends on what the agent is. Okay, so it's there are exceptions. Okay, what are some significant challenges in treating people with schizophrenia or other chronic psychotic disorders? All right, so you have to understand, and this is with bipolar as well. You know, this is a lifetime sentence for the most part of being on psychiatric medication. All right, and these medications, as you'll see when you listen to this video and then you're reading, have significant side effects, right? And it does cause emotional blunting. It can worsen negative side effects, sometimes negative symptoms sometimes. Okay, so there's that. All right. So, and that's it, right? Because that causes issues with compliance. All right. Because it's just difficult for people to tolerate, especially long term. There's issues with suicidality. One's life was, if you're diagnosed in your early 20s, the life you thought you were going to have sometimes is not realistic anymore because of the level of debilitation. Does that not mean that people who have a diagnosis of schizophrenia and schizoaffective can be productive and can reach their goals? Absolutely. In some cases, no, because the level of disability is just so severe. Okay, even with medication. So there's issues with suicidality. There's issues with occupational disability. There's issues with homelessness. There's issues with substance abuse. There's issues with poor physical health outcomes, right? Just related to the medication side effects, related to substance use, related to smoking, related to just a myriad of psychosocial factors. Okay, there's social issues, right? Like, so getting married, having children, connections, having friends. All right, so that's why when patients have schizophrenia and bipolar or schizo-psychotic type disorders, support groups are so important. Okay, social connection. All right, and just overall quality of life issues. Okay, what's a specific first line treatment? Well, it's usually a second generation antipsychotic. All right, when you're going to compare first generation to second generation antipsychotic, first of all, let me just make some clarifications. First generation is also known as typicals and typical, I'm sorry, first generation is also known as typical antipsychotics, and second generation are called atypical antipsychotics. Okay, atypical antipsychotics, second generation antipsychotics came out in the 80s and 90s. They have fewer neurological side effects, so your EPS, TD, compared to your typical first generation antipsychotics, but they still have some. Okay, it doesn't mean that they're absent. Okay, it's a lower risk. Okay, they have a lower risk of tardive dyskinesia, and just overall less side effects compared to first generation antipsychotics related to dizziness, sedation, and they're better tolerated. So there's some degree of improved compliance, except when it comes to like metabolic syndrome and weight gain. Okay, let's see. What's next? Dopamine receptor blocking in the mesolimbic pathway leads to, okay, so a decrease in positive symptoms, but also could potentially be the worsening of or the onset of secondary negative symptoms, right? Because it impacts the pleasure reward pathway. All right. So this is where you have the pleasure seeking kind of behaviors after starting medication. Let's see. Dopamine has what type of relationship with acetylcholine? Okay, so dopamine has a reciprocal relationship with acetylcholine. Okay, antipsychotics may also be used in what disorders? So treatment-resistant depression, bipolar, some anxiety. It is used a lot more, especially the newer medications and like Abilify, Apiprazole. I'm going over this slide. I think in the second video, the second half of the video I that of this video does kind of touch on it, but it seems like it's very choppy. So I just wanted to go over it really quickly because it's important that you understand it. So acute dystonia. This is involuntary movement of the muscles, often the face and the neck. All right. I think you need to watch. Please watch the video. Okay. Watch it. It is compelling, this video actually. All right. It can occur the onset is immediate to a few hours after starting an antipsychotic or changing the dose. You treat it with anticholinergics. You give Benadryl or Cogentin, okay, or both. All right. Akathisia. Akathisia, if you notice, I have a cup of coffee here. And I have this cup of coffee because it's almost an analogy, a metaphor. Imagine if somebody made you drink 15 cups of coffee and told you to sit in a chair and do not move. Because if you move, something awful will happen. Your bank account will get wiped out. You'll lose your job. I don't know. Something awful will happen. That feeling that you have of wanting to move but not being able to move is like, that is what akathisia feels like, and people feel that all the time. And in fact, the suicide rates are high with people who have very bad akathisia. So you want to assess your patient. Again, everything is assessment. All right, what are they feeling? And sometimes patients have a hard time verbalizing akathisia, so you want to try to explain it to them. And my little analogy I just gave you with the coffee, you can use that. Say, hey, sometimes patients feel like this. Are you feeling that? Okay. All right. So akathisia, it's a restlessness, internal and external pacing, leg tapping, like you can't sit still. Sometimes it's obvious, like you can see objectively that the patient has experienced akathisia because they're pacing, they're walking back and forth. Sometimes it's not. Sometimes you can't really tell. It's just like an internal feeling that they're experiencing. Okay. And so it can be treated very effectively with propranolol, benzodiazepines, and anticholinergics. I don't know if I said this, but it can happen immediately, but mostly it happens within a few days. Okay. Parkinsonism. All right, so it looks like Parkinson's disease. All right, this is motor issues. You have bradykinesia, which is slow movement, a shuffling gait, tremors, rigidity. They have this thing, it's called the Thorazine shuffle. It's like the patient is shuffling along. There's a video here. Watch the video. It takes it from just an abstract understanding to a more concrete understanding of what your patient could potentially experience. Okay. So Parkinsonism occurs several weeks after drug initiation. And when this occurs, you can treat it, but you want to stop the medication and try to switch to a different agent unless the patient has been in multiple trials or something. Okay. Let's see. I think I explained tardive dyskinesia. I'm not sure if I said this, but the risk of it increases every year. So if it goes on too long, it can become irreversible. So if you have a patient that's starting to experience you're starting to see symptoms of TD, you want to give them the VMAT2 inhibitors, and that's your Austedo. Okay. And also, you want to understand that dopamine and anticholinergic have a reciprocal relationship. Let me see if I can explain this. All right, so anticholinergics block muscarinic receptors, cholinergic muscarinic receptors. Okay, dopamine binding with D2 receptors causes acetylcholine not to be released. Okay, it inhibits its release. So when you give a D2 antagonist, it stops this negative feedback process and causes acetylcholine to be released, which allows it to bind to muscarinic receptors on specific postsynaptic cells, causing side effects, including Parkinson type movements. But when you give an anticholinergic, it prevents the acetylcholine from binding to muscarinic receptors. But because anticholinergic drugs doesn't just block the receptors on cells involved in the nigrostriatal pathway and movement disorders, but it also blocks receptors throughout the sympathetic nerve, the autonomic nervous system, throughout the nervous system in general. But in the autonomic nervous system, it can lead to peripheral side effects, dry mouth, blurred vision, urinary retention, constipation, right? And then in the central nervous system, it can lead to drowsiness and cognitive issues, impaired memory, impaired concentration, slow cognitive processing. All right. So, you want to assess your anticholinergic burden. All right. And that includes non-psych meds, all medications. Okay. To avoid the interference with cognitive functioning. And I think I mentioned paralytic ileus. Okay. According to Stahl, patients are overburdened with anticholinergic effects, but okay. All right. So is there anything else that I haven't mentioned? All right, so neuroleptic malignant syndrome. So anytime a patient is on a D2 antagonist, okay, this could potentially happen. All right, and then the labs are white blood cells and CKP. And this is because the CPK lab test measures the level of creatinine phosphokinase in the blood. CPK is an enzyme found primarily in the heart, in the brain, and skeletal muscles. So high levels of creatinine phosphokinase in the blood in the bloodstream may indicate damage to the heart, brain, and skeletal tissues, which is associated with neuroleptic malignant syndrome. All right. So guys, I apologize if this video was like split here and split there, but take the information. A friend of mine, he says, chew out the fat and eat the meat. But take what you can from it, and do your best. Okay. I also am thinking about opening up a discussion board just like for questions, and you guys can post your questions there. And then perhaps, I'm pretty sure before our midterm, I'm going to offer a live Zoom, and then I'll answer your questions on Zoom. But please post the questions first, so this way we can be as efficient as possible with our time. Okay. All right, guys, keep on working hard. I appreciate your effort. And I know that I sent an email out about texting me. The thing is, I'm teaching at Adelphi. I'm a clinician. I'm an adjunct somewhere else, and I have family responsibilities. And sometimes, the weekends is my only moments of solitude where it's just me and myself, and maybe like a cup of coffee and a nice book. So sometimes I apologize if I have been a little short. But as much as possible, please try to contact me during the week if it's time sensitive, if there's an issue with a quiz, if there's an issue that you need response that particular day, then absolutely feel free to text me or call me. But if it can wait until the week, please let's try to make it wait until the week. Okay. All right, guys. Good stuff. Take care. Bye bye.